And good afternoon, everybody. Get everything pulled up real quick. We're going to go ahead and get started with our next session. Thank you to those that have continued to be with us throughout this process. We're really happy to have you guys at our first annual tribal, I almost said tribal public health conference at our training summit, which is different than our conference. But we're really happy to have two amazing speakers here today to do a data into action for tribes training. Dr. Amanda Jantz and then Sydney Martinez are both here with you. A couple of housekeeping items before we get started. We are asking everybody to stay muted until the end of the conference. Nope, until the end of the session. I'm so sorry. And it is appropriate to have a question and answer forum. And then, you know, at the, right now we are recording this session. So just be aware of that we will be recording throughout this session. And if you would like to go back and view those recordings, that is going to be on the Training Summit webpage at the end of the summit itself. So you can go back and kind of on demand watch all of the trainings available. If you have any questions during or after the training itself, you're able to use the chat feature, or we'll have it, like I said, a Q&A at the end of the session. And then last but not least, we are going to have a little networking session on the last day of our training summit on Thursday, August 26th at noon. The first 100 attendees will receive a $5 Starbucks gift card. So we're hoping that you all will attend that and come and share what you've learned during this time. And one more thing, very important, if you want to fill out the session evaluation survey, that's going to be very important for us to, you know, take everything that that you guys say and then help us make a better virtual training summit for next year as well. And with that, I can turn it over to Dr. Jantz and Sydney. So if you guys want to get going, thank you.
All right, thank you all for being here today. I'm glad to see that we have a nice group joining so far. Let me share my screen. Okay, can everybody see my slides? And it looks like it's the presenter view.
Yes, that's right.
Perfect, thank you. So this is, as you know, we mentioned in the intro, and hopefully what you signed up for is our Data into Action course. So kind of the plan for today is we have a 2-hour session today, and then we have another 2-hour session tomorrow. So I encourage you to join tomorrow as well. So today we'll be talking about secondary data analyses for the most part, or where you can get some data from publicly available websites, and then have a data exercise and have some question and answers at the end. And then tomorrow, Sydney will be talking about developing surveys. So kind of talking about where you can find existing data today and how you can collect your own data tomorrow. So our objective is to identify tools for obtaining public health data, primarily for American Indian or Alaskan Natives, which we're covering today. And then tomorrow, we'll be talking about factors to consider when designing and disseminating a health survey. So let me put this in the chat. Let's see if I can copy them. The link to our materials, I'm going to stick in the chat box. So I'll have these at the end as well. So we have, you can either go to Google Drive or to OneDrive, depending on your agency allowances or restrictions, that sort of thing. So while you're checking for that availability, let me share my screen again. And so before, while this is up and you're looking at it, I just want to take a minute and introduce myself. So I'm, as Lexi mentioned, I'm Amanda Jantz. I'm an assistant professor in biostatistics and epidemiology at the University of Oklahoma Health Sciences Center. And I've worked with the Tribal Epidemiology Center for a number of years now. and work closely with different tribes in the state on different projects, from research projects to training development. And Cindy and I, along with another colleague of ours, have been giving trainings like these with the TEC and other groups sort of around the country over the last several years. So this is something that we really enjoy talking about. I use secondary data all the time in my work. So hopefully you guys get a lot out of it. As you have questions, please put them in the chat, and then we'll spend the last 15-20 minutes going over any questions that you have. Cindy, did you want to introduce yourself really quickly?
Hi everyone, I'm Sydney Martinez. I got my first experience with public health working at the Southern Plains Tribal Health Board. I worked there for about 4 years while I was doing my master's, and then started at the university. So I always like, collaborating still with the Southern Plains Tribal Health Board and Epicenter. And now I am doing a lot of research. My research focuses on tobacco, primarily smoking cessation among populations with diabetes. And I will be, looking forward to teaching the survey section tomorrow.
Thank you. So hopefully everybody's able to access those links have all of the presentations for today, but also our exercises. So you can do them, now, or if you get, have to leave or step away or anything like that, you have those materials. But reach out to us by email if you have trouble accessing those links. We're happy to share the materials. So we have lots of links in here that are good to have just for your future reference. And so I briefly want to acknowledge that this training was originally funded through the CDC through a partnership between the CDC and the Association of American Indian Physicians. And then we also have some material from the Great Lakes Intertribal Epicenter and also the health agency training that was developed within our college at the College of Public Health. So I just want to kind of put a little plug for some online trainings that we have put together related to data into action. So two that sort of directly relate to the work that we're talking about here are an Intro to Epidemiology course. So we used to teach Intro to Epi as part of 1 or 2 day data into action training, but it's just so much information that it's hard to cover in just an hour. It was something that we teach, a semester on. So we've made that into an online training. And then the publicly available data sources, we have something, it's kind of similar to what we're talking about today, but they've kind of made it into an online format as well. So if you follow this link, it's the South Central Partnership. They have these, the 2 trainings I mentioned, plus several others related to behavioral health and conducting a community needs assessment that are available for you to, you can take those courses. They're completely free. You do have to sign up for an account. So those are there if you want more training. So before we get going, I just want to take a few minutes. If you could enter your name, your organization or position, and then an interest in data into action training. So this kind of helps us, and you can put that into the chat because it'd be probably too complicated to have everybody go around. You could enter that into the chat. That just helps us know how to focus some of our examples. We'll be talking about, national level data, local data, and then, if there's specific things that come up that we can talk about later as well. So I'll give you just a minute to do that. All right, I see a couple of people have entered so far. I'll let, we'll keep going and then enter it as you have time. I'm sure people are still typing. It sounds like we have some interest in grant proposals and programs and that sort of thing. So we'll kind of keep an eye on that and we can talk about it as we go along. So I appreciate you guys, your input. All right, so the first kind of chunk that we'll talk about is some unique American Indian data specific issues that many of you probably are already very aware of. But as we probably all know that, who is Native American or Alaskan Native, that varies according to, who's asking the question. So the US government defines this as a member of a federally recognized tribe. The census is self-identification, and I think the census is probably fresh on a lot of our minds these days with the 2020 data being released very soon. But how race or ethnicity, tribal affiliation is asked has changed over the years as the census has collected more data. So it's self-identified, self-reported, but people, some people may only choose one group, others may report multiple groups, and that has also changed over time in terms of the census. And the census is a common source of the data that we use, especially for denominators. So, we may have a health, like the number of people with cancer over the total population, and that population data comes from the census. So it's important to understand sort of how race and ethnicity are classified in these types of data sets. By tribe, the definition may vary. It could be through blood quantum or a lineage or descent. And then of course varies by state and among individuals. I know in some areas that how race and ethnicity are classified either separately as like two separate constructs or as a combined construct can really impact how American Indians are counted, especially in the Southwest, and can make the numbers appear to be lower or higher depending on how that's classified. So that can be a challenge just to be aware of as well. And then by health and disease reporting, this also varies, and there are, we'll get into some of the challenges associated with that, whether, within health records, if race is self-reported, if the person that's collecting that data is asking people how they identify, or if they're just making an assumption and checking a box for them. And I think that's improving over time with allowing more people to self-report, but I'm sure it varies quite a bit. So in terms of that misclassification, so that, the sort of old term is, born Indian, die white. So on birth certificates, the mom self-reports her race onto the birth certificate, and that's usually the race that's assigned to the baby on the birth certificate. And there are options, for multiple races to be classified. So birth data typically have less misclassification, even though it still exists, than mortality files. So mortality data in particular have challenges because the person's obviously not going to be able to self-report their data on a death certificate, but it's often by a proxy. So whether it's the medical examiner or the attending physician, there's been a lot of trainings in Oklahoma, as well as I'm sure other places, to train the medical examiner or the person that's filling out the death certificate to ask the family how the person identified their race so that we can capture that information more accurately. Historically, this has caused an issue where mortality from cancer was underreported by about 50%. So it makes it look like cancer isn't a problem in Indian country and American Indians when we know that it is. And as we've made some adjustments to correct some of that data and collect, through linkage with Indian Health Service records that we'll talk about, but also by better, asking the question and having better self-report or better proxy reporting of race has improved that over time and has given us more accurate results. So the Indian Health Service does link with cancer registries on a yearly basis. And so our cancer data are adjusted for this misclassification. So any person with cancer, who links with an Indian Health Service record. So anybody who's seen within the Indian Health Services system, I think within the last 3 years, can then be reclassified to be American Indian. And so that has increased the cancer incidence data. For mortality, there was a nationwide linkage with mortality data across all the states that covered, I think, 99 through 2009. And then Oklahoma was able to do a linkage locally with the area Indian Health Service office for 2010 to 2015. And I think they're now working on linking the updated data, but we're getting behind as the years pass. So there's still complications. And then, so that's kind of one of our solutions for now, but of course, just collecting the data in a better way. So it's just something that you always need to be aware of anytime you're looking at secondary data, publicly available data, is to know whether it's linked with Indian Health Service and whether those rates are accurate. So epidemiology in Indian country, many of you may know this depending on your relationship with the tribal epicenters and IHS, but there are 11 tribal epidemiology centers and one urban health institute, and with a varying number of epidemiologists per site, which I haven't worked directly with the epicenter in a few years now, but I know here in Oklahoma, we're growing quite a bit. So having more and more epidemiologic support. The tribes may have epi or research departments, but of course that's going to vary. And then partnerships through universities or colleges. So we here at OU partner with multiple tribes and working with a couple of tribes on research projects that relate to both cancer and then also asthma. And one of those is through the Native American Research Centers for Health, which is a grant program funded by the National Institutes of Health. So the IHS Division of Epidemiology does allow aggregate data or to report aggregated data. So things through the GPRA measures or the Government Performance and Results Act, primarily related, or one example is diabetes, and then also outbreak investigations. And then again, it will vary by tribes and urban health centers. We've kind of talked about some of this already, but there are definitely some challenges in terms of racial misclassification and lack of data. Anytime you share data, you need data sharing agreements, which can take time to sort of, fully execute when you have the bureaucratic forces that are involved. There are also structural issues in terms of the distance between epidemiology centers and tribes, or universities and tribes, and then tribal interests. So as we all know, the pandemic has just overtaken everything. And so that informed probably all tribes, that has taken a major priority, making some aspects of epi and that sort of thing, has to have been downgraded in terms of priority just to deal with the public health emergency. And so we know that these things happen all the time. Then historical, I think probably most of you are also aware, this historical mistrust in terms of the government and researchers and that sort of thing that we have to continue to work to overcome, and lack of public health and data infrastructures, which I think this is improving over time. I'm going to skip this for now. Maybe we can come back to this when we have the Q&A session, because I just want to make sure we cover everything. And then in terms of strengths, as I mentioned, we have national data are now being linked, and that's increasing over time. We have the tribal epidemiology centers, who I mentioned are growing, with increased funding to support public health programs and to support data collection and analysis and that sort of thing. There's a big push in terms of research funding to support tribes and to understand health disparities and that sort of thing across the US. And as I mentioned, there's funds that are starting to become more available. And I think, a good thing out of the pandemic is that there are increased funds that are out and available to support building data infrastructures and those sort of things as they relate to the pandemic and other issues. Okay, so now I'm going to transition into primary health data sources. Just before I do that, are there any questions? All right. If you do have any questions, just please let us know in the chat. So as I mentioned, we were going to talk primarily today on, pretty much exclusively today, on secondary data sources. So talking about some federal and state online data sets. So our state examples come from Oklahoma. I saw in the chat there are people from outside of the state. And then we have some links that in terms of the national data that are specific to states and to find your local health department. So if you don't have these resources in your state, you can always look for them there. And we're happy to help connect you if that's helpful. And then we'll talk a little bit about clinical data. So working with the clinical health systems and sort of some things to think about when using that data. And then there's primary data, which we'll talk about tomorrow. So surveys, how to develop your own survey and some things to consider as you conduct a survey. And then you can also do focus groups or interviews, which we're not talking about this time, but we hopefully will have sessions in the future to discuss that. But that's just another way you can collect data. So first into our national data sets. So the US Census, as I mentioned, is a very rich source of data. And I'm going to pause sharing my screen so I can just share the whole, just my presentation. So give me 1 minute. Okay, I'll be able to show you the websites, hopefully, if everything goes according to plan. So all of these links are embedded here. So when you're looking at the slideshow yourself, these are clickable within the presentation. I don't want to overburden it with all the specific addresses for everything. But the census has just, in the last probably 2 years, updated their data site. So it's now data.census.gov. So I go there all the time to get data for, like I said, the population numbers when we're writing grant proposals and we need to understand the number of American Indians living in a certain area, then this is a place that I'll go to get that data. It does take a little bit of getting used to, and so it's important to spend time with the census website, have patience with it, with any of these resources, because they change all the time. And then the more you use it, the more comfortable you get with the data. But you're able to go in there and then you can often download different, Excel files if you need to, or you can develop your own report. So I'll just quickly click on this and see if everything works as expected. Maybe not. There we go. Can you see my browser?
Yes.
Okay, perfect. So this is that data.census.gov. You can go to advanced search, and again, just depending on your comfort level. So if I just type in American Indian, this will give us sort of some different pages that we can consider. And usually to get the specific data sets, it looks like these are mostly reports. Using that advanced search option is probably more helpful. And you can do some filtering. So if you know the table ID number, great, but if you don't, that's not a problem. But here's where we could go into topics and then race, ethnicity. And so it just takes a little bit of time in terms of, navigating these issues. Just kind of show you how it looks. I know we kind of go through these things quickly, and thankfully we will have the recording so you can go back to it. But my main goal is to kind of, for some of these websites, just to show you what's there so you can get an idea of what they look like. So here, if I just click on this race table, then it pops up. So this is for the entire United States, the estimated number of people, and then a margin of error. So some of, the census is, as we all know, is, conducted every 10 years for the population, but in between, the census conducts the American Community Survey. So that's why you see ACS referenced quite a bit. And these are the 2019 ACS data, American Community Survey data. And so that, because it's a survey, they have margins of error since they're not collecting data on the entire population. So we can see here that for American Indian or Alaska Native alone, there's 2.8 million that are reported as of the 2019 estimates. You can get into much more detail. You can cross-tabulate different tables. You can get these down to the state or county or even census tract level, just depending on what it is that you're interested in to make it more localized data for you. And then the Census Quick Facts is a nice place if you're, working on a grant proposal to get some really updated, just easy to find data without having to navigate the data site. And here you can select your city or town. So if I just type in Oklahoma City, then it selects Oklahoma City, Oklahoma. Now, really small towns, it may not give you data, so it will just kind of depend on the numbers. It has to be a population of 5,000 or more, so just keep that in mind. So now it shows me Oklahoma City, Oklahoma right here, and then United States. So I can quickly see the estimated total population for Oklahoma City and then for the US. And then it gives you the breakdown by age and sex, and then race and Hispanic origin. So we can see here reports for Oklahoma City being about 3% American Indian alone. So this doesn't account for those who are reporting more than one race. And then some other characteristics that may be of interest depending on the purpose of your grant. So if you can get data from here, that's great. And if not, then those data.census.gov is a nice resource. And I added a link here. There's a webinar that's being held tomorrow. I think it's during our training. So hopefully you'll still come to our training tomorrow, but they often will post, or they do post the recordings of their webinars. But this was going to be talking about some of those data.census.gov updates about, how to use the resource and that sort of thing. And they're probably coming some updates as they start to upload the 2020 data there. So just, you have that link to go refer to later. CDC Wonder is another really common data set that I use frequently. And here you can get data for cancer, which, I would do a lot of work with cancer. So this is where I get a lot of my national or state cancer data. But other aspects are included as well. So mortality data is here. It even has some population data from the census that you can get. Something that a lot of us may be hearing about in the news, the vaccine adverse event reporting data, birth data, that sort of thing. So it's, again, it's a nice go-to resource at CDC. And it's, a really pretty simple system to use. So if I just click on cancer statistics, I'm going to do an incidence request. And this is how a lot of these query systems will work, where you have, you can select different things. And we'll go more specifically through the OK to share queries, so you can get some practice with that. But many of these work much the same. If you make a mistake, then you can always reset the settings and try again. So you're not making any changes or anything along those lines. So once I'm just going to click send and they'll give us a nice table. It takes sometimes a minute depending on the query that you're looking at. But then it just gives us a nice breakdown of the different cancers. So this is just a number of people with different cancers in the US. And then you can export those data or just copy them into Excel to be able to use. So it's a nice resource as well. The CDC data and statistics page, this is a nice sort of starting point if you're looking for data on any number of topics. I have the link for where the COVID data is here in a little bit, since it's kind of got its own dedicated space. But I think from anywhere in CDC's website, you can get to those data. So this is just, again, a nice place to go, and they organize their data by topic. So if you're looking at a specific topic, then you could start there, and it should link you out elsewhere. The National Center for Health Statistics is another really nice resource. So this is where you can get the data on a lot of the surveys that the CDC conducts. So the BRFIS, we'll talk about BRFIS in a minute as well, but the Behavioral Risk Factor Surveillance System, or the NHANES National Health and Nutrition Examination Survey. This is a nice landing point to get you to those data collection systems. And some of them will have data that are easy to sort of access on their website and run some queries, kind of like we do with the CDC Wonder data. But others will link you to maybe reports, or if you have more statistical training or work with somebody who has that training, you can download a lot of these data sets and then run them in your own system. So if you have like SAS software or something like that, then you can analyze those data yourself, at least to a degree. Some of it is suppressed, and a lot of times, unfortunately, the American Indian data are suppressed. They'll be lumped in a category of other race for the public data. But depending on, if you have funding or what your question is, many of these have restricted files that do allow you to analyze the data and get information on American Indians in these surveys. You just have to go through some additional hoops and assurances to make sure that the data are safe, because they want to respect confidentiality. So that's another thing to consider. You may not see American Indian data on the face of it, but if you reach out and contact those who developed the tool or provided the resource, they may be able to help direct you to where to find the more detailed data. These links are to the Office of Minority Health and the CDC's Minority Health. A lot of these have some data resources, but a lot of times different reports that may be useful to pull some data from depending on what you're needing. So I just wanted to let you have those resources. And then this website is the Rural Health Information Hub. So can help you identify data in more localized areas. I think a nice rule of thumb anytime you're looking at these data sites or these sort of national websites is that you'll often find a data tab or something along those lines. So here we have these, the rural data visualizations in this rural data gallery or data explorer, which can often give you some ready-made maps and charts that you can just plug into your project or report, grant application, whatever it is. And then this is a similar portal on the NIMHD, so National Institute on Minority Health and Health Disparities, as part of the National Institutes of Health, has a data portal here as well. So that's another resource to consider. And then here's the link where you can go to find some of the state, local, and tribal data sets. So the CDC does list the health department directories. Just keep in mind that the websites and the links to get to those addresses change frequently. So, and I'm not sure how quickly the CDC keeps these updated, but Google is often your friend when it comes to any data source. So if the link is broken, try Googling the name of it, and that will help. So I know Oklahoma's health sites have changed addresses over time. And I think as we get to in a minute for OK to Share, I just Google OK to Share instead of trying to remember that specific address, because it pops up pretty high in the list. So speaking of OK to Share, so this is the Oklahoma's publicly available data, and it contains data linked with IHS to better identify American Indians. And not every state has their IHS linked data readily available. For the CDC Wonder site, if you look at cancer incidence data, those data are linked with IHS across the US. So that's, even though it doesn't necessarily say that anywhere, they may have added it since I last looked. but those data have been adjusted, but most other data systems have not. But one thing that's nice about Oklahoma is you can choose to look at the IHS Link data or not. So we'll show that as we walk through the queries. This is the different data sources that the OK2Share includes. So the common ones that I use are the mortality data, the birth data, and since I work on cancer data, I use this registry a lot as well. But we also have our local BRFIS and youth risk behavior system survey data. So the Oklahoma specific data where you can run some queries here. And here in a little bit, I'll show you the CDC BRFIS website as well and kind of how to walk through those tools. This is how OK2Share looks. And so I'm going to walk you through a sample query, and then this will be the data exercise that you do a little bit later in this session as well. So if you just kind of hover over here for the different types of queries, you can see the different options that you have. So our births, deaths, induced termination of pregnancies and infant mortality, the hospital discharge data. So this only includes those who have been hospitalized. So we don't have emergency department or emergency room data here, but it's those who have been hospitalized. So it's just something to consider. Our health surveys, which we'll go, again, I'll talk about those in just a little bit, but these capture our behavioral risk factors. So it's where we can get smoking prevalence, self-reported diabetes prevalence, some measures of obesity, and also immunization uptake. So there's lots of data there. And then our registries. So we have birth defects, which has been added just in the last few years, cancer, HIV, sexually transmitted infections, and hepatitis, and then the injury database as well. So here, we'll go to the final data. So they post some preliminary data, but I usually just ignore that since it is subject to change. And then select statistics. So you'll notice that the data are a little bit, sort of behind, and that's just the nature of many of these registries. It takes time to collect the data at the hospital level and then get these data to the institutional registries, so the hospital cancer registries, and then sent on to the state, and then trying to merge all of that together since patients may go, to multiple hospitals as they're getting diagnosed with the cancer. And then they have to be reviewed and uploaded and certified at a national level before they can be put into OK2Share. So we're usually about 3 years behind on the data. So, that's expected. Anytime you're writing a grant or developing a program, it's always good to at least get the most updated data, knowing that there's a bit of a lag. But like mortality data tends not to be quite this far behind. So it's all going to just depend on the nature of what you're studying. But for Oklahoma, we can go back to 1997 if we wanted to, or we can just look at a single year of data. One nice thing is you can look at county-specific data. So if you're interested in your specific tribal jurisdictional area or reservation, or a specific group of counties, then you can select those here. And what's nice is you can select multiple counties. So if I can select Adair County, it's giving me a warning I have selected the entire state, so I need to just uncheck that. So if I select Adair County, and I can use the control key to select multiple counties, and then it will run my query for those. I'm going to clear those for now. And then here's where you can do some limiting by the search. I generally don't use this step because it can cause some problems later on where you can't get the age adjusted rates. And we want, when we're comparing data, so if we're comparing cancer rates across racial groups or counties, we want to be able to remove the effective age because we know something like cancer increases with age. So if we're comparing a really young population to an older population, so maybe Oklahoma County versus a southeastern county, Oklahoma County, where the age distributions may be quite different, the area with a older population is going to obviously have more cancer just based on their age. So by age adjusting, we sort of remove age as a factor, and then we can more directly compare those two populations and see what other factors may be driving the differences in the rates. So here I usually just ignore this piece because you can stratify by these factors down below. So here you can limit your search by primary site, and I do use this often because stratifying by all these cancers can be complicated. So we have lots of different primary sites of cancer that we can look at. So one example I'll show is, so if they're highlighted with this blue italic font, then you can select these sort of double arrows here and look at more specific cancers. So here I could just select breast, excluding in situ. So those are, you know, the cancers that are often don't result in a lot of treatment that's needed, and is commonly reported out in papers and that sort of thing. And if you make a mistake, you always just hit clear and then go back. So down here is where you can define how your report's going to look. You can give it a title if you'd like. You can look at your years that are combined or separated. I'm just going to leave it as combined for now. And here's where I make all these different selections. So if I want to look at racial differences, then with the Oklahoma data, as I mentioned before, we'll want to use the IHS linked race instead of the race variable. So this accounts for that misclassification. And then I can look at, oh, here, since I picked breast cancer, actually, I'm going to start with gender and then IHS linked race. So if I had selected only females up at the top, then it often will not let me have access to these features here. So I stratify by gender and then by IHS linked race. If you don't select anything here, it will just give you the number of cancers, which may be something which you want to know, but having those incidence rates, which accounts for the number of cases divided by your population that's at risk. And that again allows you to sort of account for the population size. So like Durant, Oklahoma is going to have a lot fewer cases than Oklahoma City. But that's because there's so many more people living in Oklahoma City. So we want to be able to account for the population size so we, again, can better compare the groups. And then we always want to select our 2000 US standard here. That's our only option. Some websites may have differing options, but you always, the standard itself isn't as important as using the same one when you're working across data systems. We used to have a map option here, but that has disappeared, so just ignore that. I'm just going to hit submit request. Whoops. Oh, okay. Let me select entire state. Sorry about that. It takes just a minute to run. So here's what our report looks like. So it kind of gives us, and a lot of them will, the query sites will do this as well. So it tells me that I selected the entire state, all the years that we have available, and then this is the cancer site that I selected. So any sort of search characteristics will be listed here. It tells me that there's been 58,000 records that match that search criteria. And then I have my table here. And so we have males, and so breast cancer does occur in males, but the numbers are, quite small. And so by separating them out, then you can just, if you're choosing to look at female breast cancer, then you can ignore that and focus on these data here. So from these results, we can see that American Indians have an age-adjusted incidence rate of about 148 per 100,000 people. I'm trying to see where it says that per 100,000 for you. I think you just unfortunately have to know that. Most of the time cancer data are presented per 100,000 population. Otherwise, the numbers are so small that they're kind of meaningless. So we'll multiply that proportion by 100,000. And then the white population has an incidence rate, age-adjusted incidence rate of about 123. So we can see there's a disparity here in terms of breast cancer incidence in the state. When we see these sort of dots here, that tells us that the data are suppressed, which they define here. So if the numbers are really small for the cancer registry, that's less than 10 people in that category, then the OK to share will suppress the data to protect confidentiality. And often those rates are going to be unstable, so they're going to not be very accurate. They could change really easily by just adding 1 or 2 people to the numbers. So we want to be careful about reporting that. We do have case numbers reported for those with an unknown race, but because we don't have population data, then we don't get that information. So here it's not so much a small numbers issue as it is not having the population. We don't have a denominator for this group, so we don't have rates for them. But here in the other category for males, it looks like there are fewer than 10 people, so they didn't report even the case numbers to protect confidentiality. And one other nice and very important thing about these data sets is that you get a suggested citation. CDC Wonder does this. Really, any query system should be giving you a citation, so you can just pop that into your report or your grant proposal so that others can determine how you got your data. That's kind of okay to share, and using these queries sort of in a nutshell. Again, it just takes, practice and experience of running the data. I think it's always good if you have a report out there where they've reported some sort of cancer incidence rate, and then you can kind of compare what you got, see if it makes sense, and check that. So always just be careful, really carefully review your selection criteria as you're building that query to make sure you're reporting the correct numbers. But they're generally pretty user-friendly just once you get comfortable with them. And then for this report, what I typically do, there used to be some buttons to export to Excel, but I will just copy this table and then paste it into an Excel spreadsheet. You may have to do a little bit of formatting and moving around, but then you can have that as a nice report, or just print this and use it as your report as well, just depending on your needs. For those who work in the behavioral health sector, our Oklahoma Department of Mental Health and Substance Abuse Services has a nice query system as well. And these are only the clients that their agencies serve. So it's not everybody in Oklahoma. It's not a population-based data set, but it's a nice resource anyway, and a query system just to understand their population. Mark Reynolds is who in the past read, I think he's still the person in charge, but they have contact information on that link, so you can check it. So if you have issues with the query, it's a new person now, I should have screenshotted that, but please reach out, to them, or like you're on OK to Share and struggling, there's an email address to contact their staff as well if you find issues or getting errors or anything like that, to ask questions. So just in the last few minutes of this session before we take a break, I just want to go over some of the health topic data sets. So for chronic diseases, we have the National Center for Chronic Disease Prevention and Health Promotion, and this is where, again, you can find a lot of different links to surveillance systems within CDC. So if you navigate to the data tab from this website, then you can find these resources. And again, it just takes time searching and looking for things. You can go down a lot of rabbit holes trying to find the data that you need, but so it does just take some time to get used to it. If you're interested in cancer data, the SEER program has a lot of nice resources. They have some fast fact sheets, so you can just get some really nice figures that I use all the time when I'm teaching or when I'm putting together a report to show survival or incidence or staging of different cancers. So it's a nice resource as well. And they often will have reports for the entire US, but the SEER registries themselves are not every state in the US. So it's just a smaller grouping of them. So the BRFIS data, as I mentioned, are also just a great resource in terms of finding some national, state, or some city level data. And then you can also get data that's broken down by race or ethnicity through some of their query tools. So they have lots like prevalence and trends data just to get some quick line graphs and bar charts for certain indicators. I like this WHEAT tool, this web-enabled analysis tool. I think I have it here, just to be able to make some tables comparing maybe some like tobacco use by race or ethnicity, or cancer screenings or vaccinations, that sort of thing. So this tool, this was, to my knowledge, this is the only tool that BRFIS has with public data to be able to look at American Indian data separately. So here as we're talking about, vaccines and that sort of thing with the pandemic, I pulled data on those who reported having a flu shot within the past year among those who are 65 and older. So yes, they had a flu shot. No, they did not have a flu shot. And then the 8-level race. So I kind of truncated this table a little bit to show white non-Hispanic, black non-Hispanic, Hispanic, and American Indians or Alaska Natives who are non-Hispanic. So we can see 59% of American Indians that were 65 and older had a flu shot. And this is for, I don't have the year of this. I think it's the most recent, probably 2018 data. I have to double check. Compared to 70.9% of the white non-Hispanic population. So there's a lot of data in here. It does take some kind of getting used to and orienting to it, but it is a nice resource that they just calculate these percentages for you, and then you can plop those into a table or a report. It's not as pretty as what you can get in some of the, like that prevalence tools on Berkfist. So just take some time to explore it. And then in terms of COVID-19 data, if this is something that you're looking for, the CDC has a really nice resource page. So I tend to go to this cases and data page a lot. And they update these data daily, so 8 p.m. Eastern time. So you can look at things like vaccinations, even as low as county level. I'm just going to pick Oklahoma here. And we'll pick, let's see, just pick Tulsa County, just something different. So that kind of it zooms in on Oklahoma and then shows the number of vaccinations. So you can see down here that, there are a few states that are in this 50 to 69%, and this is the total population with at least one dose. So you can see there's just a few counties there, with a lot of our more rural counties being, at this 0 to 30% level, or maybe the 30 to 39% level. That green shade is a little bit difficult to see. But you can also look at different factors here. So we can even look at the greater than 65 years of age who are fully vaccinated. And then we see much better numbers here where it's, more above 50% for most counties. And Tulsa is still highlighted here as well. And so since we selected Tulsa County, this also just gives us a nice snapshot. So you don't have to toggle through all those if you're looking at a specific area. So just knowing that those data are available. They also have the cases, deaths, and testing data, which is also nice. Kind of gives you the overall summary, and then you could sort of toggle on this map. So looking at like the percent positive, for instance. Well, okay, not every state puts that out there, but looking at that level of community transmission, not looking pretty. But so again, this is a great resource. I find it's really easy to use. It's updated frequently. So that's, if you're looking for COVID data, it's there. And if you're here in Oklahoma, these data are not on the OK to Share data set, but they have their own coronavirus or COVID-19 dedicated website. You can just Google COVID-19 Oklahoma, and that's where you can get data here. So there's the different risks maps that the state releases once a week. And they've been maintaining data since the pandemic started. So here's kind of where at this point, they're updating this page weekly. It used to be updated daily. And then if you scroll down, so apologies for the scrolling on your screen, you can look at some nice quick graphics that you could always copy and paste and screenshot into a report. But then here's a really nice thing is that they have the data by county, by city, by zip, and then they have case data and death data. And they also have vaccine data as well. Under their data downloads, you can go, they did have vaccine data. Let's see if it's still there. Sometimes it likes to be glitchy. And testing sites, that sort of thing. So there's a lot of resources here as well. And so these are updated once a week at this point. And it's nice to see they've updated that. Unfortunately, they don't have the historical data, but they do update it, once a week, as I mentioned. So if you're looking for the state or local COVID data, this is a great resource as well. So now just a couple slides on clinical data. So kind of, now these are a lot of the resources that are out there and available. This is definitely not all of the data that are out there. There's tons and tons. Again, if you're looking for environmental data, like pollution or something like that, or climate-based data, there's resources through the federal government, but also some of the state level data as well. So this is just to kind of show you what some of the things that are out there to look for. And so in terms of clinical data, most facilities now have electronic, if not all have an electronic medical record. Not every provider uses an EMR. But this is really a really nice resource. The data are already electronic, and it has health data on individual patients. But there can be challenges in terms of accessing that data. So you often need to work with an IT or data warehouse staff, data scientist, in order to be able to get the data out of the health system. Plus you have to make sure that you're abiding by any ethical rules. So having the IRB approval, depending on the nature of the project, and then needing, the health system's approval to access those data. But the cons are that data were not collected for research purposes. So something like blood pressures, they're not collected systematically. So blood pressure is collected for clinical purposes, whereas in a research setting, we would be doing that with a very strict protocol. We're going to check the blood pressure using this specific configured machine, do it 3 times and take the average time or something like that. Whereas that's not happening in a clinical setting. And then data such as smoking, may be asked, may not be asked all the time. So there are definitely limitations to the data, but it's becoming, a rich source of health data as the EMRs are connected to each other as well. So, and it also may not contain everything that you're interested in. So I was talking yesterday, and our semester just started, and talking to my students about address data, so you can understand, are there barriers to getting from home to the cancer center for your cancer treatment, and then knowing where people are living during their cancer treatment. So we don't have really rich address data other than the most recent address that the person gave for their last appointment. So it can be challenging to look at some issues that relate to care from sort of that research or public health perspective. And the primary data, so this is often what, people that we talk to want to do. They want to collect their own data. So secondary data is wonderful. It has a lot of benefits, but it's often really difficult to find the data that you want for your local community or your tribe on a very small area, especially if it's a smaller community. So you can get sort of an idea of what's going on around you, but maybe not specifically in that community. So, once you understand where those gaps are, then that can generate some questions on what questions you need to be asking of the community. So whether that's collected through surveys or interviews, focus groups, that sort of thing. They do allow you to collect data based on your question of interest. So you can really get the data that you need for your program, for your tribe, for your agency. And it also allows you to develop a relationship with the members of the community. So you really get to know the issues that are going on there, especially if you're a part of that community, then it allows for additional richness as well. But it can be time consuming to collect. So it can take, developing a survey and then disseminating that, knowing that there are funds involved in the printing and the stuffing of envelopes and the postage costs. If you give gift cards to people for completing the survey, it can take many months to develop and get that survey out the door. And then you can need to analyze that data. So just building in that time and building up those resources is something that you need to consider as you plan your data collection. But again, rich sources of data that are very, it's important to have both. And we'll talk about those a little bit more tomorrow. So with that, I wanted to let everybody take about a 10-minute break so you can kind of stretch, get a drink or snack. And then I thought we'd use the next maybe 30 minutes to work on the data exercises. So let's meet back here at 2:05. All right, everybody, I hope you all made it back and got a little chance to stretch for a few minutes. Can you give me a thumbs up if you've been able to access the Google Drive or OneDrive links for the materials? I see that a few people have. Some more thumbs are going up. If you can't access those based on your whatever, you don't have the account or you can't through the computer that you're on, please just send me a private message through chat with your email, and then I can send those to you. I'm going to give people a couple of minutes to make sure that they can access those files, and then I'm going to send everybody to breakout rooms. So you'll be in group rooms of 3 or 4 people. And then you can work through the exercises while you're there. So there's a Word document that I'll share my screen so you can see it. That says, okay to share data query exercise. So it's titled, okay to share data exercise 2021. So you can walk through that. The first one I mentioned, we'll walk through together, but we did walk through one briefly, and I think it'll be a little bit easier to walk through in a smaller group where you can help each other, and then Sydney and I will try to bounce between the groups to check on you and answer questions. When you're in the breakout rooms, there is an option where you can ask for help. So you can push that and it sends me a message or the host a message, and then we know to come and help you. So there are 2 cancer incidence sample ones. The first one, I give you the screenshots for each step, so you can just make sure your screen matches that. And then for the second one, I give you an example, and then you walk through it on your own and see if you can get the results that I provided. And then if there's time, I listed a mortality query that's also an okay to share. At the very end is a data visualization exercise, which we aren't going to get to today. The slides that I shared do have some slides about data visualization. It's things that you're welcome to look at on your own. You'll have those resources, and then you can always practice this exercise on your own as well. So I'm going to go ahead and set up. I'll give people just another minute to look for make sure they can access the resources or ask us any questions. And then I'm going to start getting the breakout rooms ready. These will be you'll be automatically assigned, so I think you may have to click to join the meeting, and then I'll bring you back here at about 2:40 or so. Give you about 30 minutes to work on these, depending on how people are doing, and then we'll spend the last bit and give you an opportunity to ask us any questions that you have. All right, so I'm going to open the rooms now.
Hello. I don't know
Hello.
or if I need to go check on someone else.
Yeah, I've kind of gone to the different rooms. So I think there's one group that seems to kind of be that they're working on it together. I think they're about done. So I don't know if, I said I'd bring it all back about 2:40. I don't know if we should bring them back earlier to see if they have questions. I'm not sure. I think a lot of people don't have access to.
I think the group I was in was pretty much done because they don't have access to it.
Yeah, like they're either I've been able to email some, but even one person couldn't access okay to share at their agency because of firewalls. So that makes it hard.
I emailed the one that was from Oklahoma. There was
Okay.
like, okay, well. And then our newer participant didn't have a camera or microphone, so we weren't able to chat. We were talking about data sources and different things about data, but she couldn't talk. How many groups are there?
Well, I opened 7, but I think 4 with the people who are left. I think we lost some, and then a couple haven't joined a room. And I moved some people around just so that they weren't all by themselves once I saw it. So
I thought I was gonna be by myself for a minute.
well, it's always a slow process to move people around and then jump between them. It takes time, and I don't know, it'll take a couple minutes probably to get everybody back. I'm going to send a message to let people know I'm going to pull them back a little bit earlier. All right, it looks like we've got everybody back. So I just wanted to take the last few minutes. I know not everybody was able to work through the exercise, either couldn't access the files or had some firewall issues at where you work, not allowing you to access okay to share. Do you all have any questions or things, questions for us, or we can also talk about any ideas for data sources. I know if there's, we just really skimmed the surface and covered a few data sets, so I welcome any feedback on that. And then another thing I want to mention is to please fill out your evaluation form. I think that should be in the chat. And then please give us suggestions for ways that we can help improve this training, ways that we can make it interactive, knowing that people may not always be able to access the resources. Hopefully next time this will be an in-person training, and we can have some backup things there as well. So we welcome the feedback to make sure we can improve this and make sure everybody can be engaged and participate as well. So does anybody have questions for us or discussion points? You can put it in the chat or unmute and ask the question. And for those who were able to work through the okay to share exercise, or if you weren't, you can always go back to it later. But as I kind of mentioned before, a lot of the query systems are very similar in terms of giving you different options to select and that sort of thing. And You shouldn't be able to access any, patient level data, but on the off chance that you are able to identify somebody, there's often a data use agreement that pops up on these pages just to tell you what to do if that happens and not to share that information, but to let the agency know that, you found something strange, which I don't think happens often, but yeah, these, they're pretty, I think for the most part, user friendly. There's always glitches and things change. So contact those that are listed if you do run into issues. But yeah, I'm not seeing anything in the chat or hearing any questions, so we could probably just go ahead and wrap it up. I really appreciate everybody joining today, and then I hope to see you all back tomorrow where we'll talk about surveys and doing some primary data collection, which I think from earlier in the chat, there are some who are interested in collecting that local data. So yeah, we hope to see you back tomorrow, and I hope you have a good rest of your day.
Thank you, Dr. Janetz and Dr. Martinez. We really appreciate you guys coming and speaking at our first annual training summit. We're really excited to see what this becomes. Just a few closing announcements for everybody that if you need a certificate of attendance, go ahead and email. I'll put my email in the chat. You can go ahead and email me with your name and what session you attended, and we'll be able to send you a certificate of attendance for this session. You will not be able to get those certificates on the on-demand. So once they're on the website, of course, you can't get that certificate of attendance there. Only during the live training you can do that. But there's that. And then also make sure you guys join us on the 26th at noon during the lunch hour for our meet and speak. We hope that everybody will be able to be there. It's a little kind of a networking session, come collect and create some community within this virtual space that we've allotted during this time. So we hope to see you all there. And again, just another round of applause for our two awesome trainers. And we really appreciate you being here. Hope to see you all tomorrow.